Hi everyone, let's begin with the set of miscellaneous viruses under the RNA virus family that we need to know. The first one that I'm starting with is going to be the Arenaviridae family, which of course includes a virus which has arena. What is the meaning of arena? It means it has a sandpaper kind of an appearance. So you can call it either sandy or you can call it the sand sprinkled appearance. If I ask you in terms of what was different about it, it was one of the negative sense RNA viruses. Go back to the first chapter of RNA virus or just virology in general. You know that there was a mnemonic called Mr. Fab, and all the Mr. Fab things were negative sense, and yes, arena virus definitely comes under that. Talking about the next thing, it comes under a bioterrorism A agent. By now you've read a lot of bioterrorism A agents, and if you go to the right extreme end of this particular microbiology, I've put up a separate chapter called the bioterrorism ABC agents, and I've given you mnemonics as a summary also. So this is bioterrorism A agent. Talking about the reservoir happens to be rodents, and there is a known human to human transmission. So there's a rodent to human and then a human to human transmission known. What do we have to know regarding its segment? Do you remember a mnemonic called BIRA? If you go back to your general virology, again I have told you arena virus is a segmented RNA virus. And how many segments did it have? It had a total of 2 segments. Next, how do you do the diagnosis? For everything I've been telling you that you will be doing ELISA for knowing the antigen and the antibody, and because these are RNA viruses, you will be going ahead with the RT-PCR. Lastly, you would want to know what all comes finally under this Arenaviridae family. You've done all the basics, but what comes under it? What do they cause? So firstly, we've got a set of 3 fevers which are going to cause hemorrhagic fever. So the Lassa virus, the Junin virus, and the Machupo virus, these weird sounding names, are coming under the Arenaviridae family, and these are all causing hemorrhagic fever, which is the one that can involve the brain, can cause meningitis, is the lymphocytic choriomeningitis virus. The name is only telling me it is going to cause meningitis. So this is one of them which causes meningitis, and the Lassa, Junin, and Machupo are the ones which cause hemorrhagic fever. Haven't we read way too many hemorrhagic fevers by now? So right as I finish this segment of this video, I'm going to give you a list of all those hemorrhagic fevers also. Okay, this was one miscellaneous family. Now let's move on to the other one. There's something called a Reoviridae family. Now what all about Reoviridae do you have to know? Actually, Reoviridae has the most famous rotavirus, but does it also have something called the Colorado tick fever, which I've taught you earlier, because Colorado tick fever is an arthropod-borne infection. Tick, it's an arthropod-borne infection which causes hemorrhagic fever. I will be giving you an overview in the end also. For the time being, please note that there is a Colorado tick fever which comes under this family, which common sense is transmitted by tick. And then there is the most famous rotavirus, which I will be talking about, because rotavirus is famous for what all? What is gonna be the cause? So I always told you it's a rota hua diarrhea wala bachcha, right? Rota hua diarrhea wala bachcha. So diarrhea wala bachcha means it's going to have diarrhea. Diarrhea means enterotoxin. So what is the most famous enterotoxin on which they ask you a question? NSP4. What is NSP? Before I get into this entire story, non-structural protein. This means, ma'am, there is a virus which must be having some structural proteins, and then it must be having some non-structural proteins. Bilkul. When I talk about the structural proteins, we have something called VP. What all? I can see VP123. I can see VP1234 over here, and then I can see 6 and 7. So we have VP1234 and then 6 and 7. These are what make up a rotavirus. And then we have non-structural proteins. Non-structural proteins actually go from 1 to 6. But what I'm telling you is the most important one, that is 4, which is going to cause the diarrhea that I am talking about. Now they ask you what are the serotypes. So again, there are a lot of serotypes going from A to I, but A is the one which is the one causing diarrhea in children less than 5 years. So this is the question that you get. What does it cause? Children less than 5 years mein diarrhea ke liye, which are the 2 things that you have to know? What is the serogroup? Serogroup A. And what is the non-structural protein? Enterotoxin, NSP4. So coming back, I told you NSP4, which is an enterotoxin, is going to cause it. Ab diarrhea kaise hoga? What is the root going to be? The root is of course going to be feco-oral. Diarrhea ka to wahi root hai, so nothing fancy over here. This not only has a small small infectivity dose, the incubation period is also small only, roughly 1 to 3 days. So small infectivity dose, small incubation period. Okay, coming to the next thing. As I told you, it's the most common cause of diarrhea in children, and I always used to tell you one shape. Ye wala shape to dekh liya. But what was that shape? Because now with diarrhea, and I'm going to tell you a story which I told you way back in your chapter of general virology. So if you remember, rotavirus had a rotating wheel shape. Remember, rotavirus had a rotating wheel shape on electron microscopy, and I told you it was a rota hua diarrhea wala bachcha, and that rota hua bachcha was having a rotating wheel appearance. So rota hua diarrhea wala bachcha with rotating wheel is the entire story for rotavirus. So what sample will you take? No points for guessing that I will obviously be taking a stool sample. I will be doing antigen testing in it by ELISA, and I can do PCR. Of course, I will do RT-PCR because RT, it's a reverse transcriptase, it's an RNA virus. What is a vaccine and what are the side effects? Okay, vaccine, so I think you know from your pediatrics, Rotarix, Rotatrek, these are the vaccines that you have, Rotarix and Rotatec, yes, but there's one side effect of these vaccines that you have to know. If you remember, intussusception is a very important question that has been asked in the previous year papers. What is the side effect of the rotavirus vaccine? And that is going to be intussusception. Is there something about the rotavirus family that, or Reoviridae, that I'm missing out? So now let's complete the story further. Why did I emphasize on this diarrhea wala bachcha? Because this is the only double-stranded RNA virus. All the RNA viruses were single-stranded, this is double-stranded. Also, this was a part of the Beta mnemonic. This means this is a segmented genome. And how many segments did it have? Rotavirus had 11 segments. So all these features about rotavirus means, ma'am, it was segmented. Matlab, was it a part of the Beta mnemonic? Yes, it is a DS, the only double-stranded RNA virus. How did we learn it? That diarrhea wala organism is going to be double-stranded. And rota hua bachcha will remind me of rotavirus and rotating wheel. Now the full story comes back in place. So this is also done. Let's move on to another family. We have the filovirus. Filovirus or Filoviridae has two members. One is the Marburg virus and one is the Ebola virus. Marburg virus is the one that is responsible for causing hemorrhagic fevers. Again, lots of hemorrhagic fevers we're doing. I'll make a list in the end. And Ebola virus is something which is very common in Africa. Have I already told you the shape of the Ebola virus? I told you Ebola looks like a bowl of spaghetti pasta, or in other words, we said that the purpose of calling it is that it is going to be a filamentous organism. It has some filament, so it's looking like a bowl of spaghetti. Okay, so now what is the spread? It is going to be by secretion contact. So let me first show you a kind of a life cycle, because here we realize that bats are definitely coming across as one of the reservoir hosts. But yes, this is very well known in animals also. So hamare paas kaise aayega? Either it is going to come via some animal contact, right? It can be some animal contact. That animal contact can be either with a bat or it can be with any other wild animal. So once it comes to us, does it have human to human transmission? Yes, it does. There is a human to human transmission known for Ebola virus. That is very important. Human to human transmission is known. So what is the spread? It is going to be by secretion contact. You know, there are different types of Ebola that you have, out of which the Zaire Ebola is very dangerous. Okay, that is the most virulent. Which is the least virulent is Ivory Coast. Ivory is a type of a whitish color, peaceful, least virulent. Whereas Zaire is sounding very dangerous, very virulent. That is the most virulent. But there is one more strain which does not cause any infection only, and that is known as Reston. Reston is resting. It's sounding like resting. It is just resting. It is not going to cause any disease. So Ebola actually is of many types. I've got you the three main names. Number one, the Zaire Ebola is very dangerous. Then Ivory Coast, ivory, whitish color, very shant, least virulent, and Reston is totally resting. I hope you know this is a biosafety level 4 organism, and again there's a chapter right at the end of full microbiology where you will find all the biosafety levels also. What is the incubation period of this disease? Somewhere between 3 days to 2 weeks, right? So 2 days to 2 weeks also, you can remember it so that you can make it easier for your learning. Finally, guys, you should be knowing, for everything I tell you, that for the diagnosis you will have to do an ELISA and you will have to do an RT-PCR. There is no definitive treatment as such. Till now it was said that it is only going to be supportive treatment, but now there is a drug which I want to explain to all of you. For Ebola virus, there is a drug which is going to actually be a combination of three things. So Inmazeb is something that has basically been studied for Ebola virus, which has, you can very well see these Mbbs, these three Mbbs which are there, monoclonal antibodies are there, and yes, that is a trio that is now being given for the treatment of Ebola. So how I have learned it is, the Ebola ka kaunsa wala strain is like very, very deadly, very, very virulent. That is going to be Zabardast wala strain. Kaunsa hai? Zabardast is Zaire. So remember, the Zaire has to somewhere be fit in over here. So Inmazeb for Zaire is what is the trade name of the drug that comes. Similarly, using the Zaire strain, there is a Zaire vaccine also available. So this is what I wanted to show to all of you. There is an Ebola Zaire variant vaccine also now that is available, right? Okay, these are all done. Now you've done so many viruses over here. So now you actually need, you can say, a summary of two things. Which are all the viruses which are causing food poisoning, gastroenteritis, and which are the viruses causing hemorrhagic fever. So first I talk about the hemorrhagic fever wala ones, the ones which are causing hemorrhagic fevers. So right now, did I teach you that Arena Viridae family? So quickly I'll make you revise. Number one, I made you study Arena viruses, and I told you all this Lassa, Junine, Machupo, these ones were causing hemorrhagic fever. Yes, right before this we had studied a family called the Bunya virus, and if you remember, in Bunya virus you had the Crimean Congo hemorrhagic fever, Rift Valley fever, and Hanta virus. Hanta virus were rodents wala. These were all causing hemorrhagic fever. Then flavivirus, so you will never forget, dengue, yellow fever, and KFD, Kaisanur forest disease, the monkey fever. We all already know that they are going to cause hemorrhagic fevers. Talking about what we studied right now, filovirus. Filovirus mein kya kya aaya? Ebola and Marburg. They are also going to cause hemorrhagic fevers. And Riovirus, you say, ma'am, Riovirus kyun rakha? Riovirus was rotavirus. Rotavirus was causing what? Gastroenteritis. Why hemorrhagic fever? Because I just told you that other than rotavirus, this particular Rioviridae family also had the Colorado tick fever, and that tick is going to come and is going to cause hemorrhagic fever. So these are the families that you have to consider for hemorrhagic. So kya kya bana? You have the two Fs, that is flavivirus and filovirus. Then you have the Riovirus, and then you have the Arena and the Bunya virus. तो अब होगा fever. Hemorrhagic fever कैसे याद करेंगे? अब होगा fever. So please remember, Arena virus, Bunya virus, filovirus, flavivirus, Riovirus. ठीक है? Fever में V is all viruses. So which are the ones which are causing hemorrhagic fever? अब होगा fever. Okay, which are the ones which are causing gastroenteritis? Talking about all the viruses, DNA, RNA, सब कुछ. So if I ask right now, did we study rotavirus? Yes, of course. Then we have studied Norwalk virus, which comes under the Noroviridae family, right? Then we have something called calcivirus. Calcivirus, if you remember, was that hepatitis E. Of course, hepatitis E causes gastroenteritis. Astrovirus causes gastroenteritis. And which DNA virus? Adenovirus. Adenovirus, which one? Remember, I told you diarrhea ke liye you had to remember diarrhea for 40 and 40 for 40. So you had to remember 40, 41. So repeating once again, we have adenovirus 40, 41 under DNAs, and then Rota, Norwalk, Calci, Astro. These are the ones which are going to cause gastroenteritis. Yes, on that note, this small set of multiple chota organisms have been finished. Now you are obviously going to go and read the bigger organisms. Hi everyone, let's begin with the last virus in this chapter, and the one that has successfully destroyed a lot in everyone's life. So that is going to be COVID-19. So SARS coronavirus, and that is what I will be starting with, which is also given a lot of names. So COVID-19, SARS-CoV-2, Wuhan virus based on its origin or suspected origin. So yes, these are the different names. So the family that it belongs to is of course Coronaviridae, which no one will ask you. They will ask you the genus to which it belongs, and that is going to be the beta coronavirus. That is what I want all of you to learn as a question. Family, Coronaviridae, then there's a genus, beta coronavirus. How does it look like? We all know that the word corona was derived from something referred to as a crown. So before I go into the details of this entire virus, have a look at the electron microscopic appearance of this, and that is exactly how it appears. And can you see these dots? So what are those? Those are referred to as petal-like peplomers. If you remember way back in your first chapter of general virology also, I had shown you this picture. Petal-like peplomers are seen. Now let's come back. What are those petal-like peplomers? What are those projections? Those are referred to as the spike proteins, S1 and S2. And if you see, these are the ones that are going to help in attachment. So when I'll talk about the attachment in the human body, S1, S2 spike proteins are going to help. Other than that, I can see a lot of other things, like there is a nucleocapsid protein, there is a membrane protein, there is an envelope protein. There are going to be many other things like open reading frame, that is ORF. All those I will tell you in a while when I go to the diagnosis. Ye main hai, the nucleocapsid, the membrane, the envelope and the spike. And we know that this is going to be a single-stranded RNA virus, and it has nothing fancy about it. It was not at all. In fact, if you remember, when I can share that experience with you, that when I was doing my MBBS, we always used to ask our seniors to mark the important organisms which would be asked in the university exam, and this was always kind of neglected, and they would say, no one's going to ask you SARS-CoV-2, it's not very important. But now we know that this becomes a very important part of all exams, right? So there's nothing very fancy about it. Neither does it have any segment, because most of the RNA viruses don't. All the RNA viruses are single-stranded, so is this. All of the RNA viruses are positive sense RNA viruses, and so is this. So this is belonging to the usual category, but now definitely it's important. What is the size? 100 to 150 nanometers. Okay, so let's quickly talk about, there is again nothing very fancy in its pathogenesis also. So what is the first thing going to be? The first step of a virus is always going to come and attach, and I'll talk about this step in a little more detail, but after attachment everything is the same. After attachment you will say, ma'am, there's going to be an endosome that is formed and the entry of the virus will occur. Then you will take out the RNA of the virus, of course. After that you're going to make new copies, there's going to be replication, viral replication, the virus will be assembled, and then the virus will be exocytosis released. So kuch bhi aisa, matlab there is nothing very new or fancy that is happening over here, except for this attachment part, which is important. So attachment kaise hota hai? For that I've got you a bigger diagram. So all of you can see this is the SARS-CoV-2, and what does the attachment, what has God given it for its attachment? It has given the spike protein. Spike protein is going to come and attach to which receptors of our body? The ACE receptors, ACE2 receptors. So remember, the ACE2 receptors are maximally present where? They're present in the lungs. Which pneumocytes? Type 2 pneumocytes. That is why maximum involvement we saw were of the lungs. So remember, the ACE2 receptors are present in the lungs. So COVID-19 has a spike protein, that is S protein, and that is going to attach to the ACE2 receptors that are present in the type 2 pneumocytes. Other than that, you must have heard COVID patients were having diarrhea also. GIT also has ACE2 receptors. You must have heard COVID patients are having cardiac and renal problems. So these are all the places where ACE2 receptors are present, and that is why this virus is coming and getting attached over here. But you know what? We are having one more protein in our cells called TMPRSS2, which is actually not working in our favor. It is present in our body, but it is working in COVID ka favor, because who is going to activate the S protein? Remember, TMPRSS2 is a TM for transmembrane. I can definitely see it. It is through the membrane, transmembrane. So TM, PR together means it is a protease, and that protease is SS. Matlab it is a serine protease. It is a serine protease 2. So transmembrane serine protease 2 is actually going to do activation of the spike protein, and then the spike protein is going to go and bind to us. So now remember, when they will ask you TMPRSS2 is involved in which virus, it is involved in COVID-19. If on the other hand they end up asking you TMPRSS6 mutation is seen in which disease of pathology, guys? It is seen in IRIDA. What is IRIDA? Iron refractory iron deficiency anemia. Remember, it is seen in iron refractory iron deficiency anemia. And finishing it off, if someone asks you TMPRSS with ERG fusion, where in surgery do you see this? This is seen in a case of prostate cancer. These are all the TMPRSS that you have. SS2 is for SARS-CoV-2. That is what you can learn. So instead of COVID-19 over here, what I'll write is SARS-CoV-2, so that you don't get confused. So TMPRSS2 is needed for SARS-CoV-2. TMPRSS and ERG fusion is going to result in prostate cancer, and TMPRSS6, almost 6 alphabets, IRIDA, iron refractory, iron deficiency anemia. So coming back, as I told you, the attachment was based on ACE receptors and TMPRSS2. Attachment has occurred, and then I don't even feel like, asking you certain questions on how will COVID get transmitted or how are the symptoms going to be, because this is not a virus where I need to teach you these things. This is a virus which you felt, you've experienced, you've suffered from it, you've seen your friends and family and patients suffer from it. So you have so much of information already in your mind, but still, aerosol, droplet, contact. This viral is by all droplets, aerosols and contact. But what I can add to your knowledge is, before the onset of symptoms, maximum shedding of this virus occurs 5 to 8 hours before the onset of the symptoms. And this virus is culturable obviously on different cell lines. And that is going to be isolated even for the next 6 to 8 days after the symptoms. So remember, 5 to 8 hours to 5 to 8 days later than the symptoms is what is the timeline that I'm talking about. From 5 to 8 hours before the onset of symptoms, you will get maximum shedding, and 6 to 8 days afterwards, you can isolate it. What are the different clinical features? Again, I've already written it, because what can I teach you for COVID? Don't you already know patients have fever, dyspnea, dry cough, shortness of breath, anosmia, loss of smell and taste was something that almost all of us suffered from. Then in the second wave, we also started having GI complaints, nausea, vomiting, diarrhea, pain, abdominal pain. So yes, of course, diarrhea, that was a typing error. So diarrhea, yes, these are the other things, and muscle aches and pains were also there. So nothing of these which was very specific for COVID, but yeah, loss of taste and smell was something which is not very commonly seen with other viral infections, and that was seen with COVID, but none of them was like 100% finding. Everything was happening in a permutation combination in the patients. So I've also got you a few radiology pictures. What was the most common radiology factor that you saw in COVID-19? They were the multifocal GGOs. GGOs are nothing but ground glass opacity. So you can see many of the ground glass opacities that are happening. I've got you multiple pictures from the internet and the ground glass opacities that you're seeing. I'll show you another picture out here. And how is this different? Because not only do you see a ground glass opacity, you also see a consolidation. And a consolidation is like a complete whiteout. It's like complete. If I shade it completely white, that is what is a consolidation. Will you be able to see the background bronchovascular markings? No. Whereas in multifocal GGOs, ground glass, you might have seen there are some glass walls sometimes in some buildings. You can't see through them also, but they're not even opaque. They're not like a wooden wall, right? So if you can look carefully, you will be able to see a few bronchovascular markings on the background. So kind of hazy here, right? That is what is the difference between a ground glass opacity and a consolidation. Consolidation is like a complete whiteout. Okay, sometimes you see so many ground glass opacities. Look at this. Itna zyada. Now if I look, you'll say, ma'am, hazy hai. Pura white nahi hai. Hazy hai. And there are some septal thickenings in between. So this is, imagine both the lung fields are affected. This is a crazy pavement pattern. This is referred to as a pavement appearance, and you can see multiple hazy stuff, multiple ground glass opacities with septal thickening in between. Then we also see something called halo sign and reverse halo sign. Dono dekh sakta hai. So first let me tell you, if I'm talking about halo, you will say that okay, something in the center is very dense, and at the periphery it's a little light. If I say I'm talking about reverse halo, you will say reverse halo means the periphery is gonna be very dark. The periphery is very dark, and the center is gonna be a little light. So यहाँ क्या दिख रहा है? Tell me. If I ask you over here, you will say, ma'am, the periphery is very white and the center is light. The periphery is white, center is light. The periphery is white, center is light. तो ये ऐसे वाला लग रहा है. This is looking like the reverse halo, which is also known as the atoll sign. These are the different radiological findings that you could get. So अब radiology पे ये दिख रहा था, right? And you were seeing clinical features. Now comes the job of a microbiologist and a pathologist. That is, how do you do the collection of the sample? From the upper respiratory tract, we are taking what? Nasopharyngeal and oropharyngeal. Remember, one of the, you were taking one through the nasopharynx, one through the oropharynx. So ideally, nasopharyngeal and oropharyngeal samples were taken. And after taking them, what were you doing? You were putting them in a sterile tube. ये वाला tube. So this was the swab collection, one from nasopharynx, one from oropharynx, and it was being put in the same tube. What is this tube containing? This is containing VTM. What is VTM? 2 to 3 ml of VTM, viral transport media. It was containing 2 to 3 ml of viral transport media. Although it's not important, but many students do ask me, ma'am, what is a viral transport media? So it contains, see, transport. Any kind of transport media will always be something that allows the virus or the bacteria to survive. I don't want it to grow. I don't want it to replicate. I just want it to remain vital. I want it to survive. So for that, I have put in some kind of ions and some serum so that it grows, it survives. I've put in fetal bovine serum and I've put in some antibiotics so that bacteria don't grow. Here I want the virus to survive. So I can inhibit all the bacteria by giving antibiotics. So gentamicin, amphotericin B, these are the viral transport media that I have. So now, for example, you've collected your sample in this viral transport media and you say that now I have to transport it. So what temperature should I be maintaining? Like any other influenza, if you go and read Haemophilus influenza, or if you go and read any other, for not Haemophilus influenza, if I say Orthomyxoviridae, so influenza virus, if you study, you will see that you store it at a 2 to 8 degrees centigrade up to 72 hours. So if you have to do the testing within 3 days, 72 hours, 2 to 8 degrees centigrade, regular refrigerator is 2 to 8 degrees centigrade. But if you have to do the testing after 3 days, if you say that no, the lab is very, very far off, or I've done the test, but I might have to repeat it after 3-4 days, then what are you going to do? As per CDC, you store it at a -70, and as per ICMR, it was -80. So overall, you can learn between -70 to -80. The storage has to occur if there is a delay beyond 72 hours. Okay, so this is done. And now if by chance the patient was not able to give an NP-OP sample, what are the other samples from lower respiratory tract? At least 2 to 3 ml of bronchoalveolar lavage, or an endotracheal tube aspirate, or sputum. These were other things that could also be taken, but we standardized on 1 NP and 1 OP sample, both mixed in the same tube. Now let's move forward. So now this was not the only test. ये तो main test हो गया. और क्या-क्या testing कर रहे थे? We were doing blood test also. What were we seeing? We saw that these patients had something to do with NLR, neutrophil upon lymphocyte ratio. And these patients were showing a decrease in lymphocyte. मतलब denominator was going down. If the denominator was going down, this means the ratio is going to go up. It is coming more than 3.1 and it was indicative of a poor prognosis. So please remember the lymphocyte count, absolute lymphocyte count was going less than 1000. Usually it is between 1000 to 3000. So less than 1000 was what was happening. And along with that, if the lymphocyte goes down, the NLR shoots up. That was a bad prognostic factor. Similarly, patients were having decrease in platelets. That is why many people were having bleeding manifestations. We were also doing LFT, KFT. Why? Because it can result in organ damage. Troponin. Why? Because you saw a lot of coagulopathies and cardiac damage happening in patient. Then what is this? C-reactive protein, creatine kinase, LDH, ferritin, interleukin-6. These are all acute phase reactants. They always shoot up in any kind of infection. So of course I saw. In fact, we all know there is an interleukin-6 cytokine storm that was noted. Of course, and I'm again and again saying was, which shouldn't be the case, because once again, now even in 2023, once again the cases are on the rise. Now talking about albumin. Albumin has always been a negative acute phase reactant. So whenever there is any infection, albumin levels usually tend to go down. One more thing is, I kept on saying that these were also, and we all know that this is coming across as an important cause of coagulopathy. Patients are having thrombosis, clot formation. People are having stroke and MI because of clot formation. So what do you think is going to happen to the PT-APTT? Of course, the PT-APTT is going to go up. It is a kind of a clotting problem. And what is for DIC? DIC mein D-dimer is the test of choice, and D-dimer also increases. In fact, one thing is procalcitonin. If you go back to your generals of path and medicine, procalcitonin is a very important marker of sepsis, and because it was COVID and everything was going idhar-udhar, it was not falling in place, you expected any kind of sepsis, bacterial infection, procalcitonin goes up, but in COVID, viral infection, either it was normal or it was coming down. These were the miscellaneous findings that you were having. So अब हमें ये सब तो कर लिया, but I want to go back to the fact that I had collected this sample in a viral transport media. What is the test that I'm going to do on it? What were we doing? We were doing the RRT-PCR. What is RRT over here? So it is going to be a real-time. It is going to be a real-time reverse transcriptase PCR. It's going to be a real-time reverse transcriptase polymerase chain reaction. Firstly, reverse transcriptase. Why? Because it is an RNA virus. Real time, because it is going to give me a CT value. What is CT value? CT value is cyclic threshold. whenever they give you some quantity, real time is always, if you go back to your pathology lecture, you will see real time will always mean quantitative PCR. It will always mean quantitative PCR. It will give you some quantity. So it's giving me a cyclical threshold. I'll give you an example. It was said that whenever lower the cyclical threshold, higher is the load of the virus. Means if you have, I'll go in very random numbers. If you have, say for example, only one virus in the body, very, very low load. Your load is very, very less. You had only one virus. Now, for me to do a PCR, amplify it again and again and again, how many cycles will I have to carry out so that I can see that virus? I will have to carry out many, many cycles. How many cycles? Many, many cycles. I will say, oh, the cyclical threshold was very high. I had to carry out 35 cycles. Okay. On the other hand, if I say the viral load is very high, you have 1 million viruses. This is just a random number. You have 1 million viruses. You will say, ma'am, I could see it only in 8 cycles. This means the threshold number of cycles that I had to carry out were very low. So, ulta chalega. That is why they used to say that people who were having, a CT which was say 14 or 16, lower side pe tha, we were very worried for them, or 12 or 10, we were very worried. People who were having a CT of 28, 30, we were like, theek hai, never mind. Right? So, this is how it works. Opposite. Less the CT, more the load. Opposite chalega. Inverse relation, right? So, in order to simplify this entire story that I have just told you, I can simply say that CT is going to be inversely proportional to the load. Now coming back, this is a jaldi wala test. It has a turnaround time. TAT is turnaround time of 4 to 6 hours. How many viruses can it detect? Even 10 copies per ml can be detected, and we all know this is the gold standard which we are doing. So now you should know what are you must have seen at the end of every report, ek to CT value likha hota hai, that you have understood. In the end, they have also written that these were the genes that we have tested. So remember, if they have tested NSE, NSE means N gene, S gene, E gene. If they have tested NSE, those are the semi-confirmatory genes. Right? Remember, semi-confirmatory genes में S gene, E gene and M का N बनाया तो semi-confirmatory में S gene, E gene and N gene आएगा. Whereas if they have mentioned RDRP and open reading frame. What is RDRP? RNA dependent RNA polymerase and open reading frame. These are the confirmatory genes, and I'll tell you what is the use of this. So obviously these are the genes that I look out for in a PCR, but they also came across with something called CBNAT or TrueNAT, portable PCR. They said that that time when there was a pandemic going on, they wanted to reach to maximum places in the country, peripheries of the country. They wanted results to come very, very quickly. So a lot of investigations and a lot of new things were being invented. So they found out a portable PCR which can give you result even faster. See, RT-PCR was taking 4 to 6 hours. So I am talking about something which can be done in less than 30 minutes. And that was TrueNAT or CBNAT. What is CBNAT? Because something like this you do for TB also. Cartridge-based nucleic acid amplification testing. Cartridge-based nucleic acid amplification testing known as CBNAT or TrueNAT. So this was happening in 2 steps. First, you were doing the semi-confirmatory gene, E gene का screening. अगर वो ही negative आ गया, मतलब patient is पक्का negative. ठीक है? If that came positive, then you were doing the confirmatory. Only if the confirmatory gene came positive, you said positive है. If the confirmatory gene came negative, you were like, what has happened? The semi-confirmatory gene has come positive. But the confirmatory gene has come negative, तो क्या माने? One gene is positive, one gene is positive, and one gene is negative. So then you had to go in for RT-PCR. So there are, the population got segregated. पहले step पे ही negative आ गया तो negative. Second, पहले step पे positive आया, then you go for confirmation. Confirmation पे positive आया तो true positive. But confirmation पे negative आया, discrepancy आया, you were gonna compare it with an RT-PCR. But guys, what was the rapid test that we were doing? We all know it. The rapid card test. The rapid card test for COVID-19 was this test, and you all know that every card test is based on one principle. It is based on the principle of immunochromatography. So there is nothing new that I have to tell you. Immunochromatography. This I've been telling you right from malaria card test to hepatitis to HIV. Every card test is based on immunochromatography. So nothing new about it. Of course, after that, there came the antibody testing, but antibody testing by far has been one of the most useless tests because people who had good titers of antibodies, they were still getting a second attack of COVID. But the only thing is that the severity of that COVID was not very high, isn't it? So again, antibody testing, there is nothing very fancy that I can tell you. All that I can tell you that it was done using ELISA. Let's move on to the last one, because that I want to tell you from point of view of the fact that this was actually discovered by two scientists from Kolkata, India. That is why I want to discuss this. So this was a strip-based test. A strip-based test which was taking less than 45 minutes. It was named Feluda. What is Feluda? So F4, it was actually a Cas9 editor linked uniform detection assay. Cas9 matlab, what is the principle? This is based on the famous CRISPR-Cas9. So this is all that I wanted to tell you. Baki to same tha. If you were getting a double line, it was considered positive. A single line, it was considered negative. Everything was the same like a card test, but the methodology was different. It was based on CRISPR-Cas9, and Feluda is the name, and the time it takes is very, very less than 45 minutes. And also this was by Indian scientists, and that is why I want all of you to know it. Finally, all of this said and done, the last part is how did we save ourselves and what is the most important protective equipment that we need to know, and that is going to be the N95 mask. Firstly, why do we call it N and why do we call it 95? Although you studied a lot about this in PSM, I just wanted to add on little bit things about it. Why do you call it N? Because N means it is not resistant to oil. N refers to it is not resistant to oil. So maybe in the future, or maybe you've heard of something called, something called an R95 mask. R95 means it is resistant to oil. Okay? So N95 means it is not resistant to oil, and 95 means that 95% of the particles are going to be filtered. That is why you also have N99 masks, R99 masks, because 99 would mean 99% of the particles are filtered. Here you have N95, so 95% are filtered. Repeating, N stands to not resistant to oil, and 95 means 95% of the particles are going to be easily removed. So I just wanted you to know these two questions because they are going to be important for the exam. And on that note, of course, we have wrapped up our discussion. As always, I say that for, there were a lot of drugs, especially against interleukin-6 and a whole length of drugs which was invented for COVID-19 in these 3 years. So my just advice to you, if you want to wrap it all up for these things, you need to go and study the pharmacology aspect, and your entire integration will also be done side by side. On that note, I wrap up the entire discussion of the virology segment, and I hope you guys have been able to assimilate all of this. If you want to revise it in a rapid manner, go through the RR ones, and that should sort it out.